Morning. We're getting ready to start the session. The name of this session is From the State House to a Town Near You, Surgical Smoke Implementation Plan to Affect Practice Change. Let me have your attention, please, and have a seat. Thank you. We have, from the council perspective, worked for a number of years, and this is part of what you're going to hear today. But with our state taking the step to make legislation happen to work on getting us to be smoke-free is what this presentation is going to be about. What's our next steps? We had legislation passed. Now what do? We have Brenda Ulmer, past president of FAORN, past chair of the Georgia Council, past president of chapters. I mean, you've been around for a long time, being very much involved with FAORN and perioperative nursing, independent perioperative nurse consultant, educator now. We also have Christopher Hudgens that's going to be speaking today, and he's an application engineer nurse. Medical Solutions Division is where he works at 3M Healthcare. And then Ms. Pat Thornton is a nurse consultant, ambulatory centers, and she helps them earn that quad ASF accreditation. Brief introduction. If you all want to add anything else, that would be great. And we look forward to your presentation.
Thank you. Good morning. Now, how many know that we now have a law in the state of Georgia that says we should be smoke-free? Okay. And July 1st, when the law took effect, everybody was fully compliant, weren't you? All right, so we're going to talk a little bit about the journey when we started in 2019, just briefly go over that, and some other things related to smoke, which we hope will help you. And I know where the rubber meets the road is in your individual hospitals where you are having to deal with implementing what is now a state law. And interestingly enough, and I got to tell you this story real quick, I had my physical last week with my GP, who is part of the Emory system. And as part of the physical, they brought in a fourth-year medical student who, of course, had to have everything. And so he said to me, "What do you do?" And I said, "Well, mostly consulting now. I don't work in a hospital anymore." And he said, "Well, what do you consult on?" And I said, "Mostly stuff about electrosurgery and smoke." And he says, "Oh," he says, "You know, there's a law on that now." And I said, "Actually, I do know that, but how do you know that?" And he said, "Well, I was scrubbed last week on a case, and the doctors were really complaining about it." And I secretly in my mind said, "Yes, okay." So at least we're talking about it. The initiative for our smoke started in 2019. Christopher made this logo for us, and it was the initiative for a smoke-free Georgia. And from 2019 to 2022, we consistently, and when I say consistently, I mean the entire year long, work to try to lay the groundwork to get our bills introduced and to move them along in the Georgia House and Senate. We had bills in 20, 21, and 22. They went nowhere. We had a hearing in 2020, and 3 of those that recommended that the next year the bill proceed with, they wanted to see it get passed. So this year what happened was that 2 of our members, Pat's Senator Matt Brass and Holly's Senator Jay Collins, decided that they would introduce bills in their respective houses. They're both Republicans. So from March 15th, or the 1st of March when the bills were introduced, they were passed by the middle of March, which is basically the end of the session. So it just, well, that's the good news, but it just goes to show you how political things are in our state and in our country, that we were blocked for 3 years and then got everything done in 3 weeks. It was sent to the governor. It was signed by the governor on May the 9th. We were not allowed to come in and view that signing. And because there were no stipulations in our particular law, it took effect July 1st. So it is now part of the laws of Georgia that smoke be evacuated. I've heard lots of reports about things that happened. There was one surgeon who told his group of people that because of the way the law was passed, that you really didn't have to do anything. Well, that to me is pie in the sky thinking and dreaming. But the truth of the matter is, by the time the political parties finished with our bill, it wasn't what we wanted, but it is what we got. So our task, your task, is to find a way to move past that. You have to look at the entire bill. I have copies of that and can get you copies of that electronically, because it says adopt policies to protect healthcare workers and patients from smoke. A policy is not going to do that. It is the implementation of the policy. So prevent human exposure. And there's only one way to do that, with smoke evacuation. You know that. Now our law, now this is where it gets really, really complex, because I've been on the phone and writing emails now on the computer since March, trying to find out who do you talk to, where do you get an answer? And I'm telling you, it is almost impossible to do that. Our law lives in the Department of Community Health for Georgia, the entire state of Georgia, under the Division of Health Facility Regulation. That is not enough to make your eyes cross. This is the state of Georgia. Our little Department of Community Health is somewhere off in the outer edge of the org chart for the state of Georgia. But the significant thing about this little department, and this is what caught my attention in all of the research that I try to do to find out where this is going. This little department is in charge of overseeing contracts and state agreements for Medicare and Medicaid. Now, does that ring a bell in your mind? How much money do the hospitals get from Medicare and Medicaid? That is our entry into making sure these policies are instituted and implemented. Now, does Medicare and Medicaid care about what our policies are in our hospitals? They actually do. And under Title 42, on conditions of participation for Medicare, what it says, and this is deep in the bowels of all of these things, is that you have to deliver a standard of care consistent with what they expect for quality outcome results. So our state organization oversees Medicare contracts. Medicare cares about the quality, and there are financial consequences to hospitals. So when a hospital says to me, or I hear somebody say, you don't have to evacuate smoke, all you have to do is have a policy about it. My question to anyone who asks that question is, what is your tolerance for risk? Now, the Department of Community Health oversees 30,000 hospitals in the state of Georgia. This is an incredible amount, but the hospitals know that they can lose Medicare funding based on what happens with that. And so my question to this organization now is, if for some reason the Department of Community Health comes into your operating room and finds out that you do not have a policy, or you have a policy that is not being followed, what do? They may only note the record, but that's huge for us, because on this website, well, and I lost the slide there, for the Department of Community Health, and all the website addresses are at the bottom. There's a place there where it says file a complaint. So I'm not saying you need to file a complaint against your hospital or your organization, but if you file a complaint or start an inquiry process, that might be a place to start. So there are options for things to do if in your hospital you're trying to implement this law and you're not getting a lot of support from it. Now, the other I think, person who's on our side is Joint Commission, and not just Joint Commission, but some of the other regulatory agencies as well, Quad A. Hospitals want to be Joint Commission accredited, and we all think that it's because of that gold hospital standard that signifies quality. The real reason is, if they are Joint Commission accredited, then they've already met the federal requirements for Medicare reimbursement. So you've got the Department of Community Health overseeing it. You've got a law that says we got to have a policy. You've got the Health and Human Resources that say they want to see the policy implemented. Then you have Joint Commission who cares about that as well. So we have a number of places where we can go to and say, this is required, it needs to be implemented, and Joint Commission is one of those. Because the policy and procedure book that you have is your contract with your employees and the patients coming in about how care will be delivered in your hospital. Where it lives in the Joint Commission accreditation is in the leadership chapter, LD 040107. And it says that the leaders in the operating room, that is you, and all of the other leaders, have to manage and implement the policies. So everybody says that this is a policy that should be in your hospital by law, and all of the other agencies that decide whether or not your hospital gets money say that this policy should be implemented based on the standard of care. And we have tons of places that document what that standard of care is. AORN to me is your most important resource because we have a smoke guideline. That smoke guideline has more than 200 peer review research papers that support what is in that policy. You can use this actually as a guideline from setting up your smoke policy from the very beginning, or program from the very beginning to the end. In Georgia, we now have 9 states, US, we now have 9 states, Georgia was number 8, who have passed smoke legislation of some kind. As in Georgia, what we're finding out is getting the law is one thing, implementation has to go hand in hand with that, and you often have to dig for the information. So the states in blue here are ones that could potentially have some legislation. We hope that we get at least 1 or 2 more by the end of the year. I think what will happen is that eventually we will get enough states that have legislation. It'll get OSHA's attention, and it'll be a tipping point where the OSHA national organization says this is something we really need to look at. So part of the process of a smoke program in your facility is one of implementation. That also is not as easy as it sounds, and Pat Thornton is going to tell you a little bit about that.
I need an in-service on the button. Everybody, I'm Pat Thornton, and a lot of y'all know me. I not only work for several surgery centers trying to keep them Quad A certified. Quad A certification for a surgery center, thank you, ma'am. Quad A for a surgery center is the same thing as basically Joint Commission. A lot of surgery centers, especially plastic surgery centers, their board of certifications require that their surgeons work at a Quad A facility surgery center, because, you know, plastic surgeons want a lot of OR time and they don't get it from an acute care facility a good bit of the time. The only time they bring cases to an acute care facility is when they have insurance and it is related to cancer or other issues for reconstruction. The reason why I got involved in this is that I did not put 2 and 2 together how smoke affected me. Of course, I've now been in the operating room 47 years. I don't look it, do I? Yeah. I don't, but I am. And I still want to work. I still have a lot I want to give. So when I would be doing like breast reconstruction or taking off those huge breasts and reconstructing, the place was so thick with smoke when you go in there, and it's like please, somebody suck the smoke out. But then I became a director and realized I had a voice. Every time I went in these rooms, no longer than 10 minutes once I got out, my nose would bleed. I didn't put two and two together. That's what happened. And then when I go see my mother, it kept progressively getting worse. And my mother is an avid smoker. And I wouldn't even be there a few hours that my nose would bleed. And then it was like, okay, there's no more smoking in my house. And my mom didn't come to my house for months until she got used to smoking on the back porch. But there is something to this. And we need to implement this. And it makes me difficult to have to stand here. I want to walk on the stage, but they told me I have to stand in one spot. There is something that we need to realize, that you have to get some people on board. And the first thing is called the Big Five. If you don't get these Big Five on board to implement, you're really not going to get to the next step. You have got to have your CEO, the CFO, nursing administration, the Department of Surgery, as well as the Department of Anesthesia. If you don't have these people on board, you're not going to get to the next step. The next step, of course, is that you've got to have a multidisciplinary team. This is called the necessary aids. You're not going to even get to the OR until you get these necessary aids on board as well. You've got to have your nursing there. You've got to have, of course, somebody from surgery, anesthesia, risk management, infection control, administration, purchasing, and employee health. So you have to have these necessary aids there as well. Now, me saying all of this means it is a lot of work. So I need to see a raise of hands right now who has implemented already, since July 1, some kind of smoke evacuation in their facility. So I would say that's only 50%. So we have some implementation to do. You have to find a champion, whether it needs to be a surgeon. I will let you know, after going around with Brenda and talking to an awful lot of people, the biggest issue, do y'all agree, is our surgeons? Yeah. Do y'all also agree that the biggest part of your surgeons are your elderly surgeons? Do y'all also agree that the younger doctors are keeping their mouths shut and just following along with the other older guys are doing? Because they're getting the referrals, you know, and things like that. Well, that's where you're going to have to find you a champion. And I'll tell you how I did it. My surgeon, which is Dr. David Harvey, we have now got 16 smoke evacuators. Smoke evacuation in a dermatology institute is not the same as smoke evacuation in an operating room. Yes, we have a couple of big smoke evacuators that go with my ESU unit when we do really big cases. But our smoke evacuators are the ones that's got a gooseneck that goes over and sucks really close to the skin. Do you know why he got involved? His best friend got papillomas all the way in his throat, all the way down. It brought a star in his eyes and said, oh, I've got to do something. We didn't buy all of them at one time. Do you think they cut us a deal? No, they didn't cut us a deal. But we bought 2, then we bought 3, then we bought 4, and then before you know it, we had both surgery centers that we have. We have 8 ORs in one facility, and in LaGrange we have 4. Let me tell you what he does now. He says, I ain't using this coagulator, the hyphacator, or the ESU. Where's my smoke evacuator? He's the #1 person that says, I need to smoke. We have got to implement this with our grassroots. It needs to also get you a couple of champions with the doctors, but you also have to have these surgical techs want to connect, because it is a little bit of a hassle. All the doctors have to do is moan and groan, and the surgical tech bows down to them and takes it off. Am I right? Yeah. I know I'm right, because I've been there for 46 years. Whatever they want, they get. So we have to remember that we have to have a multidisciplinary team, which is the necessary aids. We have to develop the smoke policy. I have limited time, so I can't go through all this. How many people know that there is a Go Clear on the AORN national website? Raise your hand. Everything that we're saying from here on is on Go Clear. There is a copy of a policy. It's already written for you. Did everybody get a handout? I passed them down because the reason why I want to make sure y'all got the handout is that it's got a gap analysis on there. On the back side of that gap analysis is the assessment that Brenda Ulmer wrote. And actually, the majority of the stuff that's on Go Clear, Brenda Ulmer designed and helped AORN get the Go Clear information on the site. So the gap analysis is real quick. Like, how many things that do you have? In other words, the gap means what are you missing? Where's the gap? Is the gap because you don't have enough smoke evacuators and you're sharing them from place to place? Is the gap that you don't have them in your packs, you know, your smoke pencils in your packs, or do you even really need them? Because some facilities have minimal surgery, or even when you do laparoscopy, do you have the products there? You need to find out where you're missing when you get ready to have your meetings with your necessary aid. And then we need to, evaluate your equipment. Then you have to also do a pre-test with your staff. Everybody still has staff meetings, so let's make it easy. It's a 5-question questionnaire. That's all it is. You're just finding out how much knowledge they have in smoke. Then you'll know where you need to go from there on how in depth. Of course, the education should always be annually. A lot of people recommend that you do ESU and smoke evacuation at the same time. That's what I do when I did it. It needs to go hand in hand. You can't use an ESU without using a smoke evacuator. One day they will develop, and I'm looking at this young man down here in the front. One day they will make a pencil that has the smoke evacuation tubing right there inside that pencil, so it doesn't feel any different. It looks all the same. It connects all at one time. And when it turns on with a pencil, it comes off with a pencil, but it's no different in these old people's hands. We still can't get them to change the knife handle. So the smoke evacuation gap is in there, and that's the reason why I gave you your handouts. I'm not going to go over this. So it's whether you do a gap analysis or the smoke investigation tool, it's on the back. The pre-test here is 5 questions. The one that is on AORN is 10 questions. Gets a little bit more in depth on about the knowledge that you need to help teach your staff. And then, of course, the education. The one in the very middle is the most important. It needs to be done at least annually. Do y'all know that the ESU unit is the only thing the doctor doesn't learn in residency? And that's the most powerful piece of equipment he's got. But they have to get certified on that damn laser. And by the way, does anybody use a laser without a smoke evacuator? Nobody does. It comes hand in hand. Does anybody use the laser without a high filtration mask? No, everybody does. So this needs to be running hand in hand. It needs to be done annually, and it needs to be paired together. You need to have competency. Education is good, but you need to know if they know what they know. And here's the copy of the policy that AORN has it on the website. It's free for anybody and everyone. You don't have to belong to AORN to be able to get into this toolkit. Of course, the skills analysis, it's simple. Don't make it hard. The ESU is hard enough as it is to learn how to use it. The coag, the cutting, the blend, not letting the tip touch this, don't do that. I mean, make it easy, but incorporate it together. And now I am finished with my piece, and thank you for letting me talk. And I'm turning it over to Christopher.
Good morning, everyone. So I have the pleasure today to talk about research related to smoke and more specifically research that shows why we need walls, not only here in Georgia, but everywhere. So this research that I'm going to talk about today is specifically one research project that we did right here. We started in Georgia. A big thanks to Brenda and Doreen. They have been huge mentors to me, and Sharon couldn't be here today, but I've learned a lot, and so I want to thank you both. And we did a great research project that was several years in the making and found some interesting results throughout the process. and we presented some preliminary results at AORN conference last year, and we have submitted that for publication with AORN, and so I'm going to share some of those today with you. So just some quick information about the study. So the purpose of the study was to investigate the differences in patterns of behavior in the OR before and after the onset of COVID-19 related to smoke evacuation and smoke knowledge. We sent it out to AORN members and AST members. OR Today and OR Manager also sent out web links. Today, I'm just going to talk about the responses from the respondents that were registered nurses. And quickly, some demographics. So the highest number of responses came from RN circulators, about 50.7%. Years working in the OR with ESU units, the mean was about 18 years. Most of the nurses were in acute care hospitals, and the type of business most frequently responses, 61.1%, were nonprofit facilities. So this, the survey that we sent out, it was a series of knowledge-based and also clinical practice questions. This is the results of one of the knowledge-based questions. We asked the decision to use a smoke evacuator should be based on, and we gave a couple of different choices. The surgeon's preference, the patient's preference, a group decision by the surgical team, or whether the procedure will generate surgical smoke. Of course, in AORN guidelines, it does say that it should be a group decision made by the surgical team and not by one member, but the correct answer is whether the surgery will produce smoke. 75% of the respondents answered the question correctly, which means when you think about it, 21.5% answered incorrectly. So I want to look at the AORN guidelines that go along with these questions. So 2022 AORN guidelines, section 2 is on smoke evacuation and filtration, and I actually caught an error this morning. 2.1 says that you should evacuate and filter all surgical smoke. Policies and procedures under section 5 says that you should include the following policies and procedures for surgical smoke safety, evacuating all surgical smoke. One note that I want to make, so surgical energy devices, it includes more than just ESU. So oftentimes we just think about the bovie, right? But it also includes lasers, ultrasonic scalpels, dissectors, things like that as well that can produce smoke in the OR. Now I want to talk about some interesting findings from our clinical-based questions. This question was, before the onset of COVID-19, did your facility have a smoke evacuation policy? And so you can see there, 35.8% said yes, they had a policy. 44.7% said no. And surprisingly, 19.5% didn't even know if they had a policy or not. The next question that I want to talk about is the surgical smoke policy being followed? Note that 27% of the respondents that were nurses stated that the policy is sometimes being followed, and only 17.6% of respondents stated that they seldom, never follow the smoke evacuation policy before COVID-19. Interestingly, the number of respondents that said that the smoke policy was being followed after the onset of COVID-19 decreased to 20.4% to sometimes and 8.4% seldom, never. So this was surprising also to me, and some things that I want everybody to think about as OR managers is, why is there a policy in place at some facilities and it's not being followed, right? One thing that I think about is, what about our blood administration policy? What if the employees at the facility weren't following the medication administration or the blood administration policy? Would we step in and do something? Would we say something? Or would we just turn a blind eye? And with smoke evacuation, it's just as harmful to both the staff and the nurses as giving a wrong medication. And then the AORN guidelines on this, again, policy and procedure. Develop policies and procedures for surgical smoke safety, review them periodically, revise them as necessary, make them readily available in the practice setting in which they are used, and it's a recommendation. And then the next question that we asked, what percentage of cases use smoke evacuation? And before COVID-19, it was 44.9%. And then after the onset of COVID-19, it was 50.9%. This means that 49.1% of cases did not use smoke evacuation. And note only the small increase. And then the AORN guideline that deals with this question, again, evacuate and filter all surgical smoke. So thank you for letting me talk about our research study. Hopefully you'll see it soon in the AORN journal. And now I'm going to turn it back over to Brenda Ulmer.
Okay, so that's a really quick overview of where we started in 2019 and where we are today. But if you are in the process of implementing a smoke evacuation program in your facility, my message to you, bottom line is make it simple. If it's something that is complex or something that, as Pat said, your multidisciplinary committee has nothing to do with, then they're not going to be as likely to adopt using smoke evacuation. I was talking to one nurse at a children's hospital, oh gosh, a couple of months ago, and she said, my surgeon was evacuating smoke all day long and he didn't even know it. In the children's hospital, she used the Yankauer suction tip with the electrosurgery pencil and had an inline filter. I know there are hospitals here in the city that put inline filters in every single room, which is a great thing to do, and you should be doing that. I was at one hospital where the people that was the aides who work in the operating room who were responsible for changing the filters, and they came up to me and said, how often should we be changing these inline filters? Well, the answer is it depends on the manufacturer. Most of them are about a week, and they were only changing them once a month. So look at what is happening in your facility, but frequently this is for look at your cases and see how much smoke is produced, and that's in one of the policies, a small, medium, and large producing smoke cases. Oftentimes, the Yankauer suction tip or the smoke carriage on the end of the pencil with your inline filter is all you need. So when I hear people say this is going to bankrupt the hospitals, it's too expensive, it is not. Most of the stuff, with the exception of the inline filter, is already in your operating room. And those are pennies a day. Vanjie and I did a cost study of what it would cost to implement a smoke evacuation program, and it was minimal. So inline filters on every single suction system is going to help protect everyone in the room. If you need to add a smoke evacuator, the difference between wall suction, which is what you're getting with the inline filter, the inline filter pulls about 3 to 5 cubic feet per minute of smoke. Smoke evacuators go much, much higher, 30, 50 cubic feet per minute of air. So it's about capture velocity. That's why you need the smoke evacuators on the larger procedures. Give the surgeon a choice of what kind of pencil. There's a hospital up in Maryland who was introducing a smoke evacuation program, and they gathered pencils from lots of different manufacturers, cut the ends off, put them in a box in the surgeon's lounge, and let them hold them and play with them. To choose, purchasing choose a pencil and put it in the pack and put it in the surgeon's hand and say, this is what you're going to use. It's the quickest way to failure. So involve the people that have to have it in their hands and let them tell you what feels comfortable to them to help make the job easier. It's just not making it a law. Pat described one of these things. There are so many ways to do it. Operating room nurses and operating room technicians, you all are smart people. You figure out how to do tons of things. You can figure this out too. I know you can. The message is make it simple. Involve as many people as possible and don't make a big deal out of it. We have another nurse. Tram, are you in here? Can I talk about you? So Tram was at Grady Hospital working with a world famous neurosurgeon. And I have a picture of this. Sanjay Gupta, naming no names. So he wasn't evacuating smoke. Tram goes into him one day and she puts the smoke evacuation pencil in his hand with the smoke carriage, and she says, we're going to use this today. He says, oh, okay. That was it. That was it. Don't make a big deal out of it. So Tram texts me a picture from the operating room saying, this is Dr. Gupta using smoke evacuation. No problem here. So you have a better relationship with the surgeons than anybody does, you and the technicians. So work together, make it simple, don't interrupt the flow of surgery. And that's one of the things that attracted me to surgery in the beginning, is the ebb and flow. It's like watching a ballet, to see a surgeon and a circulator and a scrub tech, and the way that they dance back and forth to complete the procedure in really what I consider to be a fantastic form. It's still to this day amazing to me to watch it. Make it simple. Don't interrupt the flow of surgery. Find a way to do it. Here, one of these pictures, the tech is just holding the edge of the smoke evacuation tubing up to it. Find a way to do it, and don't make a big deal out of it. This is a surgery, a neurosurgery, and this is one of Vanjie's pictures. It was a neuro case, and we know that neurosurgeons can sometimes be a little testy. They got a hose, a regular smoke evacuation hose, punched holes in the side of it, and hooked it up to the smoke evacuator. I mean, that's ingenious to do that. And it solved the problems. Nobody's hands has to do it. So keep it simple, make it easy, work together as a team. A number of different ways to do it laparoscopically as well. So, you want that laparoscopic smoke cleared out so the surgeon can see, but you also want it filtered so that everybody else in the room is not having to breathe it and the patient is not absorbing it through their peritoneal membrane. Look at what is available, find out what works for you, and make it simple. And that'll be the easiest pathway to success.